Yes, ma'am.
Respected participant, Assalamu alaikum. I am Dr. Sharmin Abbasi. Welcome you all to a very important session of Planetary Health Academia, Shock in Obstetrics. All of you know that Planetary Health Academia is an international platform for us where we can work jointly with the Bangladesh fellow, with the USA, UK, Australia, and other countries fellow. So this is an important platform. Through this platform, moreover, 14 countries fellow joined with us to enjoy the session. And we are very much privileged for today's session because today's session is a very important session for our fellows. And according to the importance of our fellows, we actually set the topics, we actually set the time, and we actually set the speaker and the panelist link also. So today we will talk on shock in obstetrics, and we all know that there is a high rate of maternal and fetal mortality is due to shock in obstetrics, and still Bangladesh and other country also fighting with this condition to combat and to save the life of maternal and fetal. We are very much privileged that today we have a very good options of the panelist chair and the speaker with us. And with me, the co-moderator today is Dr. Raunok Jahan. Dr. Raunok Jahan is an OBGYN and high-risk pregnancy specialist, and she is the assistant professor of maternal and fetal medicine of the Shohid Sarwardi Medical College and Hospital. As advisor, we have Professor Laila Arjuman Banu. Professor Laila Arjuman Banu is the Honorable Advisor of Planetary Health Academia also, and she is the Chief Consultant and Head of the Department of Ops and Gynae Labate Specialized Hospital, Dhaka, Bangladesh. She is the President of PCS Club of Bangladesh and Bangladesh Perinatal Society, and she was the past President of the National Society of Obstetrical and Gynecological Society of Bangladesh. With chairperson, we have Professor Farhana Dawan. Professor Farhana Dawan is a proud chapter of Bangladesh. She is the present leader of the National Society of Obstetrical and Gynecology, Deputy Secretary General of the South Asian Federation of Ops and Gynecologists, Professor of the Department of OBGYN Ibn Sina Medical College Hospital, Deputy National Coordinator FIGO LDI Project, FIGO PPH Bundle, FIGO PPIOD Project, and the Honorable Secretary General of Bangladesh Chapter of Organization of Justices, Organizing Secretary of Endometriosis Adenomyosis Society of Bangladesh. And she has a huge range of academic achievement and work experience because she worked many different government medical college in Bangladesh and served, and she is a pioneer and the builder of the many doctors of our country. Please welcome Professor Farhana Dawan to today's session. And as another chairperson, we have a proud name, Professor Rubina Sohel. This name is a name of inspiration for the obstetrician and gynecologists of the South Asian region. She is the past president of the SAFOB, consultant OBGYN at Hamid Latif Hospital, Lahore, Pakistan, champion of sexual and reproductive health and rights, chair of FIGO Committee of Violence Against Women, and widely published, including the National and International Journal, the Lancet, the Bulletin of American College of Surgeons, author of a many book and chapter, and awarded of the Young Gynecologist Awardee and FRCOG attendant in 2019. Please welcome Professor Rubina Sohel, Madam, with us. So at the beginning, I'm requesting Professor Laila Arjuman Banu, the Honorable Advisor of today's session and also the Advisor of the Planetary Health Academia, to give the welcome speech. Please, Madam.
Thank you very much, Dr. Shamin. Actually, I must give also I congratulate and give acknowledgement to this Planetary Health Academia because of their day-to-day the important discussion of the important topics. So today the very important topics that we know that the shock in obstetrics. And we all know that the obstetric shock or shock obstetrics is defined as a life-threatening cardiovascular collapse syndrome associated with pregnancy, childbirth, and puerperium. And there are actually 4 types of shock, that is hypovolemic, cardiogenic, obstructive, and distributive. Among these, the distributive is destructive is the main or the dangerous type because there are maternal mortality is so high, so we should have some special consideration for this type. And I think our today's speaker, actually, I have forgotten Dr. Sharmin has given so much wide elaboration and description, so I did not repeat. But I must congratulate all the dignitaries here for a beautiful good evening. And then actually, hemorrhagic shock, we know the management and everything will be done by Professor Firoza Begum, which is a renowned fetal-maternal medicine specialist. And she is the speaker today. I think she will give or enlighten us with her recent knowledge and updates. And also, there are some special emphasis should be given to the management of the obstetric shock, because of you all know that this is the main cause of the maternal mortality. And if you don't take the proper proper control and proper management immediately, then we will lose the mother and fetus. So I think this is the when you get a patient, but without any thinking, you just shout for help, and all the modalities you should have. So I think it's a very important session, very important topics, and our juniors and participants will be benefited very much. Even then, I must give congratulations to our chairpersons, Professor Farhana Dewan, Professor Rubina Soil, which is a very good friend, and speaker, Professor Firoza Begum, our president-elect, and sorry, and Dr. Tasbirul moderators, Sharmin and Dr. Raunuk Jahan already you have heard, and also the panelist, the Dr. Tasbirul, he is the chairman of the PHA, Dr. I think the Professor Kaisar Shardar, he is the head of the Department of Bartem Anesthesia and Pain Management. Dr. Rehana Zaman from UK, I think she will join later on. And also, I think these are the panelists list. So without any sparing any time, I think we should start the session. And I give the microphone to Sharmina Abbasi. I think she will continue the session. Thank you.
Thank you, Professor Laila Juman Madam, the Honorable Advisor of the Planetary Health Academia. Now we go to the main core scientific part of our today's session. As a keynote speaker, today we have Professor Firoza Begum. Professor Firoza Begum is a great mentor and a great teacher in the chapter of Bangladesh, and the many students have passed with the hand of Professor Firoza Begum, and they become the fetal maternal specialist also. Professor Firoza Begum is a reputed obstetrician and gynecologist of Bangladesh. Her credentials include wide clinical experience and distinguished academic career. She is the president-elect of the Obstetrical and Gynecological Society of Bangladesh, president of the Maternal Fetal Medicine Society of Bangladesh. Under her direct guidance and leadership, Fetal-Maternal Medicine Wing was established in Bangabandhu Sheikh Mujib Medical University in 2004, and she became the founding chairman of Fetal-Maternal Medicine Department of BSMMU in 2018. Her field of expertise is preeclampsia, birth defect, and assisted reproductive technology. She is the vice president of Bangladesh Society of Medical Genetics, vice president of the Fertility and Sterility Society of Bangladesh, ex-editor of Bangladesh Journal of Obstetrics and Gynecology, member of the ESHRE and SMFM, more than 75 publications in reputed national and international journal. She has author of textbook on high-risk pregnancy for postgraduate, which is a very much popular textbook among the Bangladeshi fellows, and she awarded Young Gynecologist Award by Folk. Though her knowledge, experience, and foresightness and leadership, she has been playing a key role in the improvement of maternal health in Bangladesh. Please welcome Professor Firoza Begum. We are very much privileged and proud, madam, to get you in today's session, because in our session already 104 participants joined to hear your lecture, and more than 2,000 with the social media. And from Brunei, from Nepal, from India, from Pakistan, more than 14 countries fellow joined with us in today's session. Please welcome Professor Firoza Begum.
Can I share my screen now?
Yes, madam, please.
Okay.
I'm requesting the participant, please put your question in the chat box and question answer session. The best question asker will get a very exciting gift, and the PHA will send you that gift. So please write your important question in the chat box and question answer session. Madam, please share your slide.
Thank you, Sharmin, for your kind introduction, and thanks for inviting me in this program. Respected chairpersons, Professor Rubina Sohel, past President SAPO, and Professor Farhana Dewan, President OGSB. Learned panelists, Dr. Taskirul Islam, Professor Kausar Sardar, Dr. Rehana Jaman, moderators of this session, and dear participants from home and abroad. Assalamu alaikum and very good evening to everybody. I will talk about shock in obstetrics. But before I start my presentation, I would like to share with you the story of Mrs. X. Mrs. X is a
Madam, to screen share, please. Would you screen share?
Mrs. X is a 33 years old lady, para 3 plus 2.
আমরা কিন্তু দেখতে পাচ্ছি না স্ক্রিন।
Oh, sorry.
Share screen, জি।
I have to start again. Share screen.
প্রেজেন্টেশনটা ওপেন করে জাস্ট শেয়ার স্ক্রিনে দিয়ে দাও।
Yes, share screen. Now you can see, Sharmin?
No, madam.
Not now.
আপনি
Okay.
সব অফ করেন, করে আবার আপনি প্রেজেন্টেশনটা ওপেন করেন, করে শেয়ার স্ক্রিনে দিয়ে।
তাই তো দেখতেছি।
দুবার দিবেন তো শেয়ার, একবার দিয়ে আবার দেন।
কিছু একটা সমস্যা হচ্ছে আমার, I don't know what is it. Now can you see?
Yes.
Okay.
এখন ফুল স্ক্রিন দিতে পারবেন। জি, জি
Okay.
ম্যাডাম।
Thank you,
Okay, you
Sharmin.
can continue.
Now, I have already mentioned, I want to share with you the story of Mrs. X. Mrs. X, she is a 33 years old lady, para 3 plus 2 spontaneous abortion, all vaginal delivery. She was brought to the emergency of one of our busy tertiary care hospital at her 39 weeks of pregnancy with the history of vaginal bleeding and intense lower abdominal pain. Her attendants gave history of trial of labor at home using oxytocin. On admission, she was disoriented. Her blood pressure was non-recordable. Pulse was 126, very low volume. She was anemic like paper white, dehydrated. Her abdomen was tense and tender. Uterine contour was irregular, and fetal heart sound was absent. On vaginal examination, vagina was full of clotted blood and cervix was 7 centimeters dilated. Her diagnosis was a case of hypovolemic shock due to uterine rupture. Dear participants, obstetric shock is a life-threatening medical emergency and is the most significant cause of high maternal mortality throughout the human history. Shock is defined as a state of circulatory inadequacy with poor tissue perfusion and generalized cellular hypoxia. Now, the obstetric shock is mainly due to massive hemorrhage or sepsis, but it may be due to cardiogenic cause or it may be due to extracardiac cause. If I classify obstetric shock according to the pathology, it may be hypovolemic shock due to hemorrhage, fluid loss, or burn. It may be obstructive in nature due to cardiac tamponade, pneumothorax, pulmonary embolism, or it may be distributive type like sepsis or anaphylaxis. Again, it can be a cardiogenic shock due to myocardial infarction, cardiac arrest, or tamponade. Now, what are the different types of shock? The features I have already mentioned, hypovolemic shock may be due to burn, may be due to hemorrhage, or may be due to fluid loss. So there will be hypotension, tachycardia, weak and thready pulse, cool and clammy skin, urinary output will be low. In case of cardiogenic shock, and it is due to failure of the heart to pump effectively. So there will be global hypoperfusion with oliguria, altered mental status, and there may be pulmonary edema if there is accompanying left-sided heart failure. In case of neurogenic, anaphylactic, and septic shock, there is generalized vasodilatation. In neurogenic shock, there is failure of the sympathetic control on the vascular tone, and in septic shock, it is due to the inflammatory mediators. And in anaphylactic shock, there is presence of vasodilator substances like histamine that results in loss of systemic vascular reduction or loss of systemic vascular resistance, causing inadequate cardiac output in spite of normal intravascular volume. So how we'll manage this shock? The goal of management is to quickly detect the location or cause of bleeding, if any, or injury or inflammation, prevent the progression of the shock, prevent massive transfusion, and preserve the uterus and preserve fertility if possible. So the initial step is it should be a multidisciplinary team approach. The team includes the senior midwife, an obstetrician, an obstetric anesthetist, a senior intensivist, and a neonatologist. Once the patient is admitted, we should identify the stage of the shock. We can make a rapid initial assessment of the patient's level of consciousness by using the ABPU method or by using the Glasgow Coma Scale. Place the patient in a Trendelenburg position and start basic life support with assessment of the airway, breathing, and circulation. Secure and maintain the airway, that is, and assist ventilation as needed. We know in the pregnant woman, she is more likely to regurgitate and aspirate in the absence of secured airway, and therefore the airway should always be protected as soon as possible by intubation with a cupped endotracheal tube. The patient should be given 100% supplemental oxygen, and IV access should be opened with 2 wide bore needle, and fluid resuscitation should be started with crystalloid solution. We should try to prevent loss of body heat and control any obvious bleeding, and also put a Foley's catheter to monitor the urinary output. If the patient is still fetus in utero, we should start fetal monitoring. And in unconscious patient, we should check the blood glucose level. And if it is less than 4 millimole per liter, and give immediately initially with 50 ml of 10% dextrose solution, this can be increased to up to 250 ml. And monitor the response of the therapy, that is pulse, blood pressure, and partial pressure of oxygen by the pulse oximeter, and also note the urinary output and its pH. Monitor the need or access or need for arterial line, central venous line, or pulmonary artery catheterization. In addition, order for the blood or blood products. And finally, there is a need for vasoactive drugs in some of the conditions. And these are considered, vasoactive drugs are actually considered if there is shock thought to be due to myocardial depression or profound vasodilatation, but it should be administered only after adequate fluid resuscitation. These drugs have no role in hypovolemic shock. Now, I will talk a little bit in details about the different types of shock. First, the hypovolemic shock. In hypovolemic shock, the circulating blood volume is inadequate, resulting in acute depletion. It may be due to hemorrhage or it may be a non-hemorrhagic shock. Now, the hemorrhagic shock. Hemorrhagic shock is associated in pregnancy, is associated with postpartum or post-abortal hemorrhage. It may be due to ruptured ectopic pregnancy, placenta previa, abruptio placenta, rupture of the uterus, as well as during the obstetric surgery. Hemorrhage may also be associated with disseminated intravascular coagulation, intrauterine dead fetus syndrome, and amniotic fluid embolism. Now, the non-hemorrhagic shock. Non-hemorrhagic shock may be associated, that is a fluid shock. It may be associated with excess vomiting, diarrhea, diuresis, or it may be due to supine hypotension syndrome due to compression of the inferior vena cava by the pregnant uterus. Now, the pathophysiology. We know in shock, there is circulatory inadequacy due to disparity between circulating blood volume and the capacity of the circulatory bed. The net effect of this inadequate exchange of carbon dioxide and oxygen between the intra and extravascular compartment, there is a stagnation of carbon dioxide and other metabolites in the tissue leading to metabolic acidosis. There is depletion of the ATP and sodium and potassium pump dysfunction, which results in cellular edema with accumulation of sodium. And finally, there is destruction, intercellular lysosomes are destroyed and toxic substances enter the circulation. There is capillary endothelial damage. And finally, there is cell death. Now the different stages of shock. In the first stage, that is in the compensatory stage, our body can compensate up to 500 to 1200 ml of cardiac output. That is 10 to 25% of the total blood volume. Even if it is lost, it can be compensated by centralizing the volume, moving the full fluid into the intravascular space, and increasing the cardiac output. So at this stage, the patient will show only tachycardia. There will be normal or slightly lower blood pressure, and diuresis will be normal. In the second stage, that is decompensated state, body has already lost 25 to 30% of the total volume, and there will be decreased circulation, especially in the liver and kidney. So there will be oliguria or anuria, and there will be patient will show clinically will get hypotension, rapid and thready pulse, agitation, restless, and confusion. In the third stage, that is the irreversible stage, there is complete failure of the compensatory mechanism. There is profound decrease in perfusion, which leads to cellular death and organ failure. There is metabolic acidosis, lactate and acetoacetate accumulates. There is decreased myocardial perfusion and contractility, and ultimately there will be there multiple organ dysfunction syndrome. So what is the management? The principle of management in obstetric hemorrhagic shock is to stop bleeding and replace the volume that has been lost. Restore the circulating blood volume by using blood transfusion and infusion of fluids. Now, in case of obstetric PPAs, we should follow the PPAs care bundle, the components of which are uterotonic drugs, isotonic crystalloids, tranexamic acid, and uterine masses. The initial stage, along with intravenous fluid, we should give intravenous uterotonics. If intravenous uterotonics are not available, along with fluid resuscitation, we can give sublingual misoprostol. If the PPAs occurs in the context of placental retention, every attempt should be made to remove the placenta, and if there is laceration, they should be repaired. In case of refractory PPAs, compensatory measures include aortic compression, bimanual uterine compression, intrauterine balloon tamponade. And non-pneumatic anti-shock garments can also be used if the patient is in a primary or secondary care center and already she has delivered. So in this case, to shift the patient to higher center. Now, regarding the tranexamic acid, the recommendation is that tranexamic acid should be used as soon as diagnosis of PPAs is made, if the diagnosis is made within 3 hours. But if the more than 3 hours have been elapsed since delivery, there is no clear evidence of benefit from tranexamic acid. The dose is 1 gram IV over 10 minutes, and if the bleeding continues after 30 minutes or stops and again restart within 24 hours, a second dose may be given. The women trial found that tranexamic acid reduced the death of the women with PPAs by 20 to 30%. Also reduced the incidence of laparotomy due to bleeding by 36% and was not associated with increase in the adverse outcome. Now, I will talk about the shock index and the rule of 30. Shock index is the ratio of the heart rate to systolic blood pressure, and in the non-pregnant woman, this ratio is 0.5 to 0.7. In the pregnancy, the ratio is 0.7 to 0.9, and if the shock index is more than 0.9, it is associated with increased mortality and increase the likelihood of blood transfusion. So this is a simple clinical tool we can use to detect the degree of shock. And the rule of 30 is that approximate 30 is an approximated blood loss of 30%. That is defined by a fall of 30% of hemoglobin, fall of 30% of hematocrit, fall of 30 millimeter of mercury of systolic blood pressure, and a rise in the pulse rate by 30 beats per minute. This shock index, together with the rule of 30, are important tools that may aid clinicians in an emergency to determine the amount of blood loss and the degree of hemodynamic instability. Dear participants, in obstetric massive hemorrhage, we should avoid large volume of crystal wires. Blood transfusion should be keep up with the blood loss. And the massive transfusion protocol, which is predefined, there is a predefined ratio of packed RBC, fresh frozen plasma or cryoprecipitate, and plus platelets in the ratio of 1:1:1 or 2:1:1. It is essential to follow the coagulation panel. That is, if the INR is more than 1.5, start with fresh frozen plasma. If the platelet is low, that is less than 100,000, start with platelets. If the fibrinogen level is less than 200 milligram, start with cryoprecipitate. Whenever we give cryoprecipitate, we should use 10 bags. Now, the endotoxic shock. Endotoxic shock is associated with, in obstetrics, is associated with septic abortion, chorioamnionitis, acute pyelonephritis, or puerperal sepsis. Usually, it is caused by gram-negative organism, and most commonly is the E. coli. Other organisms occasionally responsible are Pseudomonas, Klebsiella, Proteus, Bacteroides, and Arobacter. Septic shock actually has 4 stages. In the first stage, there is systemic inflammatory response syndrome. And in this stage, there is temperature is slightly elevated, respiratory rate and heart rate is also increased. WBC count may be high or may be low. Next stage is sepsis, where we will get 2 features of SARS along with confirmed or suspected infection. In the third stage is severe sepsis, that is sepsis along with end organ damage, severe hypotension, systolic blood pressure less than 90, and lactate. And finally, there is septic shock. In the septic shock state, there are 2 phases of septic shock. Here, the bacterial endotoxin causes selective vasospasm at the post-capillary end. So blood is pooled in the capillary blood bed, and the patient in the early septic shock therefore feels warm due to vasoconstriction. In the late phase, patient feels cold, skin becomes cold and clammy or ashen gray, and this is called cold shock. There is inhibition of the myocardial function, and cellular damage occurs through complex biochemical changes. No, so how will we manage this septic shock? The management is aggressive hemodynamic resuscitation, use of supportive measure to correct the hypoxia, hypotension, and impaired tissue oxygenation. Identify the source of infection and treat with antimicrobial therapy, surgery, or both. Antibiotics should be started with empirically, including the broadest spectrum bactericidal as well as those covering the anaerobes. Now, the neurogenic shock. Neurogenic shock is a distributive type of shock, and there is often hypotension and bradycardia. It is caused by disruption of the autonomic nervous pathway, and in obstetrics, neurogenic shock may occur due to after spinal anesthesia, manual removal of the placenta without anesthesia, or depressant action of some drugs. Now, shock due to amniotic fluid embolism. Amniotic fluid embolism is a rare, unpredictable, unpreventable, and devastating obstetric emergency which occurs in 2 to 6 per 100,000 pregnancies. It is signaled by the triad of hemodynamic and respiratory compromise in addition to disseminated intravascular coagulation. The management of amniotic fluid embolism is supportive rather than specific, as there is no proven effective therapy, and mortality is high. So these patients require immediate aggressive respiratory and hemodynamic support, and coagulopathy should be managed with aggressive volume replacement and initiation of massive transfusion protocol. Some patients may need replacement of the clotting factors. Cardiogenic shock. Cardiogenic shock, I have already mentioned, is caused by failure of the heart to pump effectively, or there is cardiac malfunction. Obstetric cause of cardiogenic shock is due to coronary spasm, cardiomyopathy, pulmonary or amniotic fluid embolism, Mendelssohn syndrome. In addition, it may be due to valvular heart disease or dissection of the coronary artery or acute left ventricular failure. After initial management by the ABC approach, in cardiogenic shock, the patient, we should seek help from the cardiologist. Now, shock due to drug overdose and toxicity. In obstetrics, common cause of drug toxicity is caused by magnesium sulfate in presence of renal impairment and by local anesthetic agents, which has been inadvertently introduced into the vein or systemic absorption of toxic amounts administered via an appropriate route. The local anesthetic agent toxicity includes sudden loss of consciousness without tonic and clonic convulsions, cardiovascular collapse, and sinus bradycardia, and along with conduction defect. In case of magnesium sulfate toxicity, there will be loss of deep tendon reflexes, respiratory depression, and cardiac arrest. The antidote of magnesium toxicity, you all know, it is 10 ml of 10% calcium gluconate given by slow intravenous injection. In case of local anesthetic agent, we should immediately stop injecting it and lipid rescue should be used. Lipid rescue actually reverses the local anesthetic toxicity by extracting the lipophilic local anesthetics from the aqueous plasma and tissue, and by counteracting the local anesthetic inhibition of myocardial fatty acid oxidation. Finally, there is anaphylactic shock. Anaphylaxis during pregnancy occurs most commonly due to use of antibiotics, non-steroid anti-inflammatory drugs, and as well as intravenous iron. There is intravascular volume redistribution, cardiac output is reduced, there is acute ventricular failure, and myocardial ischemia may also occur. Treatment of anaphylaxis is, in all cases of anaphylaxis, all potential causative agents should be removed, and the treatment is 1:2000 adrenaline, 500 microgram given intramuscularly, and this dose can be repeated after 5 minutes if there is no effect. Adjuvant therapy includes chlorpheniramine and hydrocortisone. Dear participants, I will end my presentation by showing you the burden of shock in 2 tertiary level hospitals in Bangladesh. One is Shere-Bangla Medical College Hospital, where every year more than 20,000, 21,000 patients get admitted, and every day 6 to 8 patients come with shock. In the Mymensingh Medical College, this is another big medical college hospital, but total admission yearly is around 45,000. And every day 15 to 18 patients come with shock. So shock is a critical and life-threatening medical emergency, but we are facing this emergency every day. One of the biggest challenges in shock, obstetric shock, is that sometimes we cannot predict it, and therefore we need constant vigilance for the patients. A logical structured approach using ABCD should be used in assessment and management of such patients. And CPR should be modified during pregnancy by securing the airway as early as possible and displacing the uterus manually, especially if it is more than 20 weeks. An obstetrician should lead the multidisciplinary team of the management of the critically ill pregnant women, and all staffs should have annual drill and update on obstetric emergencies and resuscitation. Thank you all for your kind attention.
Thank you, Professor Firoza Begum, Madam, for your very wonderful and evidence-based presentation, Madam. And you perfectly told about our challenges, our difficulties, our limitations, and how we combat the shock in perfect way. But with your lecture, it is very clear that we should have a very clean-cut concept regarding the pathogenesis, pathophysiology, and also the management aspect. So thank you very much, Madam, because it will be very helpful, because when we're giving the lecture, we saw there are near about 160 students with us and fellows with us to hear your lecture. Would you please stop your screen share, Madam? Kindly, please. So I'm now requesting from the chairperson point of view. First of all, I'm requesting Professor Farhana Dewan, Madam. Professor Farhana Dewan, Madam, is a president of the Obstetric and Gynecological Society of Bangladesh. Madam, you heard about the presentation of Professor Firoza Begum, and she perfectly told about the present situation, and last of all, give data from two big hospital of our country. So from your point of view, what you are thinking regarding how we combat shock in our country to reduce the maternal and fetal mortality? Professor Farhana Dewan, Madam, please.
Thank you, Dr. Sharmin. Respected Laila, my friend Rubina, and all the audience and the panelists and dignitaries. Assalamu alaikum and good evening. I think I would like to congratulate Firoza for an excellent presentation, because it is a very difficult topic, but she has spoken so well, and it was a bit easy, though it was a bit, the sites were quite busy, so people might have had difficulty in following her. So I would like to begin from where she ended, because I think the last few slides were very important for me. So I would begin with what she told about the sepsis, because I feel that sepsis is very important, and I don't, for the death due to sepsis, in 2016 BDHS, it came that the death was 7%, but before that in 2010, it was 1%, and before that it was like the death from sepsis was more, like it was 70%. So I believe that, I don't believe in that in between statistics. That means that sepsis is a big chunk of cause taking maternal death, maternal lives. So for that reason, I think people should have a good insight of sepsis, septic shock, and how to manage. Secondly, regarding the amniotic fluid embolism also, because I have a very scary experience when I was in the head of the department at Shohid Saradi Medical College. I was sitting in my room when I was called from my doctor. She was just, two doctors came rushing that, madam, we are just delivering a patient and she is going in shock. And the patient's attendant was just at the head of the patient, and the anesthesiologists were called, ICU doctors were called, but we couldn't save her because she suddenly developed, just after delivery, she developed amniotic fluid embolism. So I think that the person, my message is that the person who is there should know the whole thing, should be trained, and should know how to manage on spot. That is very important. It will be the midwife, it will be the doctor, it will be the junior doctor, it will be the senior doctor, whoever will be in charge, whoever will be in duty, that person has to know, identify the shock, give the initial management. Before ending, I would like to say a few words on PPH bundle. Appa was mentioning, Firoza Appa. So there are actually 3 bundles. The first is the AMTSL. We talk about AMTSL also as a bundle, and there are 2 more bundles in PPH management. One is the first response, and the second is the refractory. So how AMTSL is a bundle? First, bundle we have, for example, we tie 3 or 4 sticks with a thread, string. So the sticks here are the injection oxytocin, delivery of the placenta by control contraction, and fundal massage. And the strings are that initiating breastfeeding, looking for tear, emptying the bladder. So this is the MTSL. And the second bundle, the first response bundle, there are 4 things: IV fluid, injection oxytocin, injection tranexamic acid, and the initiating the IV fluid, then oxytocin, tranexamic acid. And along with this, there are the 3 things. That is the immediately check for tear, empty the bladder, empty the uterus. And in the refractory bundle, there are 4 things with 3, 4 plus 3. What are the 4? One is the bimanual compression, one is the aortic compression. And the other 2 are the UBT, NAST. These are the 4 which are the initial ones. And the string, there are 3 strings again here. That is the immediately opening the IV channel and giving oxytocin, doing surgery, referring the patient. So I think these bundles, if you remember this, because in the emotive trial, they have found that still women are dying from PPH because immediately we are not doing these procedures all in a bundle, although it is mentioned as a bundle. And so at the end, I will like, before ending, again, this is the real end. I would like to mention that the challenge of shock, challenge of management of shock, Appa has rightly said that we cannot predict, and for that reason, treatment is delayed. So the persons who are involved, again, I would like to say, persons who are involved with, we who have done who teach the LSS training in like BCPS and all other places, we know that what is ABC, what is CPR, and it is very important. Hello, Mrs. Still, like we should do the drills, and that will be very good for the persons to know. And this is another example of simulation, which we talk about in the BPH bundle training group. Thank you so much. Thank you, everybody.
Thank you, Professor Farnadon, madam. Your talk is always a guidance for us, madam, and you are doing very hard work with our society to reduce the maternal mortality in our country, especially with PPH bundle and also the other obstetrical emergency. And as a evidence, it is showed that to work with a emergency obstetric care, you have a great leadership and a great contribution in our country. And thank you for that. Thank you, madam, for joining with us. Now I'm requesting Professor Rubina Sohel, madam. Professor Rubina Sohel is an inspiration for the obstetrics and gynecologists of the South Asian region. Professor Rubina Sohel, madam, would you please comment on the presentation of Professor Firoza Begum? And at the same time, would you please highlight the works of the SAFOG to reduce the maternal mortality due to obstetrical shock, what SAFOG are doing in the South Asian region countries? So if you highlight it so our fellows can know about SAFOG also. Madam, please.
Thank you very much, Sharmeen. I begin by congratulating you that you have started this series of educational activities and the lectures that you have started. World-class standard. The speakers are excellent, and you moderate the session very well. It's always a pleasure to be here with you. Professor Firoza actually talked on a topic which, from the perspective of the South Asian region, is very, very important for us. And I think the level of deliberation presented to us actually took care of all the salient features of management of shock which should be talked about. So I think that the only comment that I have for her particular presentation is to facilitate her on this excellent presentation that she made. I'll just put a couple of things in perspective about what we talked about. And I'm so glad that Bangladesh is doing the PPH bundle approach. And in Pakistan, we have also started the PPH approach by our own efforts. So it's not a full-fledged supported program, but we are doing our own effort. So I think one of the most important lessons that we have learned with this bundled approach, and before that, is that hemorrhage should be prevented. And if there is any way that we can prevent the hemorrhage, I think that would be the best choice for all of us, that the patient should not have hemorrhage. However, that is not possible. So I think that considering the incidence and the burden of anemia in the South Asian countries, so what we have started doing in Services Hospital, where I worked and I recently retired from there, we made a plan that in all the patients who are coming to us, booked for delivery, at 28 weeks, we will check their hemoglobin. So we used to calculate the hemoglobin deficit from an average of 11. And by the Genzoni's formula, we would transfuse carboxymaltose injection to the woman. So our target was that every woman who delivers in our hospital should have a hemoglobin of 11. And honest to God, it is easy to say, but when you really see the things happening, we entered a trial and lo and behold, we had no book patient with a hemoglobin of less than 11. So if your patients are going into maternity with a hemoglobin of 11 or more, the probability of postpartum hemorrhage due to atony is going to reduce. So I think this is one important point that I would like to add to what Madam Firoza said, that we need to be working for making sure that we have an anemia-free South Asian region. And we could actually, the next term is coming, so we could actually make it a point, and Farhana is going to be there, I'm sure. So you could be one of the leaders for talking about this, because in Pakistan, we have already started it and we need it for every country. The second thing is, I think, which is very important, because hypovolemia is the most common the shock that happens. So I'm going to first talk about hemorrhage. So I think that the visual assessment of blood loss at every delivery is the second most important thing. Why does shock happen? When the volume that is lost is significant, then shock is going to happen. So if we are able to diagnose PPH early, then the probability that even if shock happens, it is going to be irreversible and it's going to be severe, the likelihood decreases. So the first message is eradicate anemia. The second message is do a visual assessment of blood loss at every delivery. And I think the third message is that our trainees and doctors need to be trained to know how to replace the fluid lost. Because when we are doing PPH workshops in our country, my anesthetist friends, they always call me and they say, PPH workshop without an anesthetist, how could this be possible? So I have added 2 slides of role of anesthetist in PPH management. But what I say every time is that the anesthetist who should be our partner should be an obstetrical anesthetist, not a general anesthetist, because a general anesthetist would not know what type of fluid to give, how fast to give, what not to give, and they will actually make the patient die, not make the patient die, but they could possibly lead to death of the patient because of improper use of fluids that the patient needs. So I think this is a very important concept, that what kind of fluids we need: isotonic fluids. We need crystalloids. We don't want to push colloids into the patient too much. We don't want to give too much blood transfusion. So I think that the proper use and proper administration of fluid replacement in a patient with hemorrhagic shock can save a life. So these are my couple of points from the point of view of hemorrhagic shock. When we come to infectious shock, I think the most important thing to learn is that even if we keep on giving antibiotics, till the source of infection is not taken out, the patient will not recover from that shock. So I think that it is important. So for example, if the uterus needs evacuation, then the products of conception, until they are removed, the patient will not recover. So I think this is one thing which needs to be kept in mind. And the second is the use of corticosteroids in those particular patients for a short while at least. The third type of shock, I think, which we should be talking about is thromboembolism, and shock which is sudden pulmonary embolism happen and the patient collapsing. To me, that is the most scary kind of shock, and in that, it is very difficult to save the life of the patient unless we are very alert. So my last comment probably would be talking about obstetrical team response and talking about simulations. We need to ensure that in our wards, in our workplaces, we conduct regular simulations so that when a condition of shock happens, first of all, our doctors and trainees are able to diagnose shock, then able to find out what is the cause of the shock, and then provide appropriate management so that the life of the patient can be saved. But you would agree with me that since we have started doing the PPH bundle approach, the type of hemorrhage that we used to see previously, that has significantly reduced because of balloon tamponade, because of the presence of the anti-shock garment. That much bleeding is not happening anymore. And if we are able to expand this PPH program all over the country, then probably the amount of blood loss will decrease. But training for the management of blood shock, for identification of blood loss, and then for management of shock, I think is of prime importance. Now I come to the second half of your question, what is SAPOG doing? I think the biggest feather in the cap of SAPOG is this PPH bundle approach strategy, which was implemented as a program, and we were able to collaborate with FIGO, and we thought of the PPH was more interested to support Bangladesh. And I was very happy because of that, because it does not matter when we are doing programs, which country is doing the program. The important thing is it a country of the South Asian region? And if it is a country of the South Asian region, it makes me feel very, very happy. So I think that one feather, and India is also doing PPH bundle approach. Sri Lanka probably does not need it. And Nepal is also sensitized to PPH bundle approach. So I think we need to take forward the PPH bundle approach. We need to gather data, and we need to start talking about data, that what is the number of lives of women that we actually saved when we managed the patient by the PPH bundle approach. I think Farhana, you being president of the OGSB, if you can bring up that data, I think that would be lovely. And if I can help bringing out the data from Pakistan, we can do a joint publication from India, Bangladesh, and Pakistan, talking about how we can save the lives of the women. So I think this is very important. And the second component, as I said, that we have already started on anemia eradication, and Pakistan has started on it, and so has India. I'm sure Bangladesh is also doing something about it. But I think that this is our next agenda, that we talk about anemia eradication in South Asia. Thank you very much.
Thank you. Thank you, Madam Rubina Sohel, for your kind words. And you are the one of the best leader of the SAFOG also, we all know. And with your leadership and Professor Farnadon, Madam, also with you, I think South Asian region will work more extensive with all the country of the SAFOG in future to combat this type of complications and to reduce the maternal mortality also. At the same time, I'm now requesting Dr. Raunuk Jahan, but the participant, you have a very good news, because Professor Rubina Sohel will give a lecture on obstetrics violence is very soon, I think upcoming month. So it will be the very good session, and I welcome all of you to add with us in that very particular, because this is a very uncommon lecture, because we actually not commonly get this sort of lecture. So, Madam, I think it will be a very great addition. Thank you, Professor Rubina Sohel, Madam, for joining with us. We have many questions in the chat box, but we will take the questions later on from the Firoza Begum, Madam, and also take a comments from Professor Laila Juman Banu at the end of the session. But we are going to the very exciting panel discussion session. For the panel discussion session, I am requesting Dr. Raunuk Jahan to conduct it. Dr. Raunuk, please.
Assalamu alaikum. Am I audible?
Yes.
Assalamu alaikum. My respected advisors, chairpersons, my respected teachers and senior and junior colleagues, and very good evening today. And I want to give thanks to the organizer for arranging such a important and critical topic discussion. And now the second part of the topics discussion, and this is the part for hearing from panelists. Let me introduce our panelists today. There are three panelists. Firstly, Dr. Tasbirul Islam. Sir is a chairman, PHA, Planetary Health Academia, and clinical associate professor, Chicago Medical School, Rosalind Franklin University, Indiana University of School and of Medicine, and board certified in internal medicine, pulmonary, and critical care medicine. Published over 20 papers in peer-reviewed journals, member of the Royal College of Physicians of UK, and former executive member of Central B Mana from 2017 to 2019. And he awarded with the Golden Apple Stethoscope Award for excellence in teaching at the Drexel and our Drexel University of College of Medicine. Now our second panelist is Dr. Rihanna, and Dr. Rihanna Zaman. She is faculty lead PHA, consultant obstetrician and gynecologist at Noble's Hospital, Isle of Man, UK. Her special interest on menstrual disorder, pelvic pain, and cervical problems. She is member of various societies, including the British Society of Gynecological Endoscopy, British Society for Colposcopy and Cervical Pathology, member of the Advisory Committee, Bangladesh Liaison Group, RCOG, and chairperson of the group. Now, the third panelist of our today's discussion, Professor Kausar Shodgar, and sir is head of the Department of Anesthesiology and ICU and Pain Medicine, Bardem General Hospital and Ibrahim Medical College. He is also Secretary General, Bangladesh Society of Anesthesiologists, Critical Care and Pain Physicians. Now, the question answer, before question answer session, I would like to go to the panel discussion session. Firstly, to Professor Tasbir sir, As shock develop for acute and diffuse hypoperfusion, and there is accumulation of metabolites. So first recognition and management is very important for improvement of maternal fetal outcome. In this perspective, so after initial treatment, which parameter will guide us to shift the patient to HDU or ICU? That means we want to know the admission criteria of patient in HDU or ICU. And at the same time, we also want to know when we will shift the patient or step down the patient from ICU or HDU recovery suite. The Professor, please.
Thank you so much. Thank you so much. I really appreciate it. And thank you so much for your kind introduction. Really, first of all, I want to thank the speaker for a wonderful presentation, though I missed part of it. Because I was rounding in ICU and it's a couple of sick patients I have to deal with. But it's a wonderful presentation. I think it's a very relevant in that shock in obstetrics because it is can be a life-saving intervention. And I think it's very important to know how to deal with a shock patient. And I want to thank the chairperson and the advisor and the rest of the panelists. As you said, we deal with the shock patients all the time in ICU as intensivist. And first thing you should know that the two ways they can diagnose shock. One is looking at the vitals, that is the blood pressure and heart rate. And then looking at the labs, especially what we look at is the lactic acid. It's a very important marker. If someone has lactic acid going up, it's a very bad sign. So if you look at the vitals, some is hypotensive and tachycardic, that will tell you patient going to shock. And the number we look for, systolic less than 90 and MAP less than 65. And you always, when you treat the patient, you try to keep the pressure, the systolic more than 90 and diastolic mean more than 65. The another important is you may see some because someone is pregnant. That means you're dealing with very young population. They're really a fighter. That means they can keep their blood pressure. Try to keep the blood pressure normal despite they're sick. So in that case, you will see the lactate is going up, and by definition we say when the lactate is more than 4, even the blood pressure is normal or low normal, we call it shock. So that is number one. And number two is, so whenever you see the lactate is going up, though the blood pressure doesn't look bad, bring the patient to HDU or ICU, number one. When the pressure is very low or patient's tachycardic, that is a sign the patient should come to the ICU. Yes, there is problems with the ICU beds. There is a problems with the HDU beds. There's a limitation resources, but still you have to be very vigilant and try to make the bed for the patient. The important thing you should do to figure out what causing the shock. We know it could be hemorrhagic shock, it could be hypovolemic shock or cardiogenic shock or septic shock or obstructive shock like from tamponade or pulmonary embolism or anaphylactic shock. It's an important tool to find out what kind of shock you're dealing with is the echo. So everybody should know how to do bedside echocardiogram. It's small probe. We all do echo now at the bedside. That is, we call it point of care ultrasound. You put the probe. If you see the left ventricle is not moving, cardiogenic shock. If you see the right ventricle is not moving, it's a pulmonary embolism. If you see the big pericardial effusion, tamponade. If you see the left ventricle is hyperdynamic, think of septic shock or hypovolemic shock. And looking at the IVC, if it is collapsing, it's a hypovolemic shock. So just putting the probe on the chest, you know exactly what kind of shock you're dealing with. So I know in the setting of OB patient, mostly is the hemorrhagic shock or cardiogenic shock or septic shock. Again, the pulmonary embolism is very common in those population. So echo is a very helpful tool. Number two, you should give fluid. The initial fluid, 30 cc per kilo ideal body weight, not the actual body weight. Ideal body should be given for any patient. Regardless of fluid status, like patient has congestive heart failure or patient's dialysis patient, don't worry, just give the first fluid. Subsequent fluid, you assess the fluid responsiveness. Number two is start vessel pressure early. If someone is in a hypotensive, don't just give fluid. Then after a few hours, start in the liver norepinephrine. No, start the norepinephrine with the fluid. Sometimes the pressure is 70s or 80s. That's number two. So don't delay in initiating the vasopressors. Number three, the choice of vasopressor is the liver fat or norepinephrine. Number four, give antibiotics, and it should be given within an hour, because sometimes they don't know what shock you're dealing with. And sometimes very difficult, because the one important maneuver intervention you can do to improve the mortality is the antibiotics in the setting of septic shock. If you delay in giving antibiotics, it will increase the mortality or decrease the chance of survival. So in summary, I will ask everybody, the trainee, to learn how to do the bedside echo. Number two, check the lactate. Even the lactate more than 4, even the blood pressure is kind of low normal, that is, patient is going into the shock. Number 3, give fluid, and that is the balanced fluid you give, not the normal saline. Number 4, if you suspect septic shock, give antibiotics within an hour of diagnosis of shock. And I'm more than happy to take question, but thank you so much for having me.
Can I just comment, Sharmeen, if you allow me, on what Dr. Tasbir has said?
Yes,
Yeah.
madam, definitely.
Firstly, Dr. Tasbir, you made some very pertinent, excellent points, and especially the one with the echo. Thank you very much for that. I just want to reiterate what he has said, because this is, I think, also called the 1 hour bundle. And 1 hour bundle is basically the management strategy for septic shock, which says that we should start with giving the blood culture, then measure the blood lactate levels, then follow it up with an antibiotic, use of norepinephrine, and also make sure that we give fluid at a rate of 30 milliliters per kg of body weight. I think that this is all very important, and the steroid that I said is basically for refractory shock if the patient is still not responding. And there was a question in the chat box about the evacuation of the uterus after in septic shock. What we do is that if we have given the dose of antibiotic, we would evacuate the uterus early, sometimes maybe as early as an hour after giving the antibiotic and after starting the management of the patient. So I'll stop over here.
Wonderful, madam. Thank you. Dr. Rao, please.
Thank you, madam. Now, I would like to request from Professor Kaushal Sardar. Sir, would you hear me?
Yeah.
Sir.
Yeah, can
Sir.
you hear me?
If I give
Yes.
a scenario to you that a young lady is going through the labor process and suddenly she developed cardiac arrest, then what standard cardiac monitoring should be there, and is there any updated protocol? We want to know from you, sir.
Yeah, thank you very much for the invitation. And first of all, I want to thank Professor Firoza Begum, madam, for your excellent presentation about the obstetric shock, and all the chairpersons, moderators, advisors, and panelists along with me. Yeah, first of all, for this case scenario, it's a hemorrhagic shock and followed by cardiac arrest, right? So you want to know about that, right? I think.
Yes.
Yeah. So for the shock, hemorrhagic shock, first few cutoff values is to be noticed. Number 1 is the hemoglobin level, that is the 7 gram per DL. When the hemoglobin level comes down to 7.7 below, the alteration in the oxygen carrying and also the hemodynamics comes, it is altered. Before up to 8, 9, and 10, it can actually, body can compensate this one. So when this is one cutoff value, so we have to keep the hemoglobin level above 7. Number two is the cutoff value for the mean arterial pressure. The mean arterial pressure, two things. One is important organ is our central brain. That is, it requires for the perfusion, at least mean pressure should not go down to the 60 millimeter of mercury. And for the kidney, it's a 50 millimeter of mercury. So this value is very important. Anyhow, you have to keep the patient, the blood pressure above that, mean pressure at least 60 millimeter of mercury. And how? How is a big question. So you have to be very prompt. You have to be very well set up. You should have a very good transfusion unit there. You have to be very much prepared before starting all of your procedure. You have to assess the patient from very early, and you have to be very prepared. Then you have to go for this type of procedure. Otherwise, you will fall in problem, because this is not very easy. You just asking some blood, the blood will come to you very immediately. You are asking for fresh frozen plasma, so it is coming to you. So your preparation is very important. So these are the things you have to be careful about that. If you get nothing, so you can support it by the crystalloid solution in the first few time, but your hemoglobin is very important. You need RBC, and otherwise you can't hold the blood pressure above 60 millimeter of mercury, because the viscosity of blood is very important. So when the blood is become less viscous with huge load of crystalloid solution, so blood pressure, you will not get the good blood pressure there. So that's why you need RBC. So you have to be prepared very well, and you have to transfuse and or infuse very properly. And you have to start multiple channels. You have to give the central lines, and you can check if you put a central line, so you can assess the patient now very nicely. So moreover, if you have more monitoring facilities in your hospital, in your setup, that you can manage this type of patient more accurately. You see, the blood pressure is equal to cardiac output into peripheral resistance. And further, cardiac output is equal to stroke volume into heart rate into peripheral resistance. So ultimately, blood pressure is equal to stroke volume into heart rate into peripheral resistance. So this three component actually control the blood pressure. So which one is required? Sometimes you need to the more venous return. You need increase the end diastolic volume. Sometimes you need good when the end diastolic volume will be good, you will get a very good stroke volume. Sometimes you need handle the heart rate issue. Sometimes you have to handle the peripheral resistance issue. So this can be monitored by the advanced monitoring system. Like you can see the stroke volume even by a machine. You can see the stroke volume index. You can see the cardiac output even. You can see the cardiac output index. So what is my ending of your talking is that if you fail to monitor and if you fail to resuscitate the patient in this scenario, then it may fall in the cardiac arrest. So, but very unfortunately, cardiac arrest for a hemorrhagic patient in a hemorrhagic shock is a very difficult situation to, it doesn't respond on CPR actually, because heart is empty, na? So there is less end diastolic volume there. If you compress the heart, the stroke volume is very less because there is no blood in the heart. There is a hypovolemia actually. So this is actually, it's a very difficult situation. So for the cardiac arrest, you have to follow the ABCD standard rules. and you have to resuscitate patient with the RVC and fluid. You have to make it U volume as maximum as possible. Thank you very much.
Thank you, Kaustubh Sardar sir. Actually, I think as we have to give proper antenatal care. So that's how we can identify the high-risk patients and we can manage properly. And another thing is that you properly mentioned about basic life skill training. And if it is mandatory, it becomes mandatory for each and every healthcare provider. Then basic life skill training can help our mothers and we can save our mothers. So thank you, sir, very much. And
one thing, Raunak, is the current scenario in our country very unfortunate actually. What you have raised, the second question actually, that one, the pre-operative assessment, this is not done properly in our country. This is very unfortunate part. Some big hospital and corporate hospital, we are doing very nicely this one, but the clinics, it's a horrible situation actually. I think if we can establish this thing, pre-operative assessment of the patient. So in pre-operative assessment, look, some patients may have some cardiac problem in the pregnancy. This is not, this is uncommon, but not very uncommon. It can be, because a lot of patients in their puberty, in their childhood age, we have the incidence of the rheumatic fever is not less in our country. So patient may have some valvular disease, may have, if the patient have the aortic stenosis especially and the spinal anesthesia, it's a very dangerous situation actually. So it will produce as well as hemorrhagic shock, it will invite the cardiogenic shock, it will invite even in the neurogenic shock even because of the spinal anesthesia and your manipulation of the pelvic organ for the huge parasympathetic stimulation is there. So so you can prevent a lot of death if you evaluate very properly if the patient have some cardiac disease. This is not uncommon, I was saying, that at least 1% of the pregnant lady, they have some cardiac problem. This is the UK data actually. We have no data about it, but this the UK data is 1% pregnancy, they have some sorts of mild to moderate type cardiac problem. So this should be evaluated very properly by the anesthesiologist before the operation for the further planning. And it may require some optimization of the symptom before going surgery. By that, we can take the help from the cardiologist also. So if we're doing this in a multidisciplinary approach with all patients, especially we establish the pre-anesthetic checkup for every patient in the clinics and lower levels. So I think we can prevent a lot of death like this. Thank you very much.
thank you very much, sir. Now we may go to the question answer session. Dr. Sharmin.
Thank you. Thank you, Apap. Dr. Tasbir sir is raised hand. Sir, do you want to add anything here? Dr. Tasbir sir?
Yeah, thank you so much, Sharmin. Yeah, just a couple of just some of the supplements what was discussed so far. One is the antibiotics should be given within 1 hour, and you should give a broad spectrum antibiotics. Don't think of giving narrow spectrum, then what? Start with the big gun, then narrow down. So de-escalation of antibiotics. And number two, don't wait for the central line to give the vasopressors. If the patient is dropping blood pressure, start vasopressors through the peripheral line. It's very safe if we use 18 or 20 gauge, not 22 surely, but 18 and 20 gauge. Nowadays, actually, we give it vasopressors to the 18 and 20 gauge, wait for 24 hours, still requiring vasopressors are going up the dose, then we put a central line, because we don't want the patient to get central line associated or CLEPSY, central line associated infection, bloodstream infection. That's number two. And number three, I would suggest that the cultures, keep an eye, do the pan cultures, make sure you don't look at the blood cultures, they do the urine cultures, they look at the chest x-ray, then decide what kind of infection you're dealing with. Important message from here, start with big gun, then de-escalate. Start vasopressors to the peripheral line, 18 to 20 gauge. Don't wait for the central line and delay to give the vasopressors. And number 3, safely you can give vasopressors to the 18 and 20 gauge for 24 to 48 hours without any extravasation to the tissues. Thank you.
Thank you. Thank you, sir. We have lots of questions in the chat box. We will take the important questions, and I am requesting Professor Firoza Begum, Professor Rubina Sohel, Professor Kausar Shardar, Dr. Laila Madam, and Dr. Raunak, you also can add with the panel question. First of all, I come to Professor Firoza Begum, Madam. One of our student asked you that what is the role of heparin in amniotic fluid embolism? Madam, unmute yourself and please give the answer. Yes, Madam. Professor Firoza Begum.
Yes.
Unmute করবেন, Madam.
Okay.
Yes.
There is definitely, there is in amniotic fluid embolism, we know that is debris and everything and goes into the, goes into the actually in the chest, and it causes one kind of blockage. That is one type of, it causes blockage, and ultimately there will be, as there is tissue thromboplastin, so there will be DIC type of bleeding. And so in this case, what was your question?
What is the role of aspirin, Madam?
Pardon. Role of
Yeah, heparin. Heparin.
heparin. Here, actually, there is, I don't think, I don't know actually, is there any role of heparin or not, but there is a role of actually blood coagulants, that is factor 7, there is a role, and there is a role of, as there is a DIC, so there is a role of massive transfusion protocol, and this is all. Heparin actually causes when there is clot formation, heparin helps it, but this is not like that. This is actually a blockage. So heparin, I think it will not help. I don't know. Somebody else.
Professor Rubina, do you want to add anything, Madam?
Yeah, I just want to add this, that in a patient with pulmonary embolism, heparin or Clexane are life-saving, and they must be given immediately, because pulmonary embolism is not directly related to massive hemorrhage or not. So as if your patient is suddenly becoming dyspneic, she is throwing out frothy pink colored fluid, you must suspect, and there is hypotension, you must suspect pulmonary embolism, and Clexane or heparin must be given immediately.
Okay.
Because that is going to...
Professor Kausar, if we want to go for any operation or anything and patient suspected amniotic fluid embolism, is it create any problem to give heparin to the patient?
No, heparin is good. Heparin is good. You see some pregnant lady, they have deep vein thrombosis. This is in the Western world and the Middle East. This is very common, I think. So they give the prophylactic heparin to prevent the thrombosis in the deep veins, and the mortality rate is very high for the thromboembolic manifestation. So you have to give it earlier. If you give, especially the more low molecular heparin is advisable here. So this is prophylactic. So it will help. It will help to prevent.
It will help. Okay. Okay. Thank you, sir. Thank you. Regarding the prophylactic antibiotic, there are many questions. For the developing country or the low hygienic area, there is many chances of infection. So, Professor Firoza, Madam, in our country context, what is your take-home message? This prophylactic antibiotic for all the obstetric patients who are undergoing normal delivery, normal cesarean section, or vaginal delivery. Do you support it, Madam?
Actually, the asepsis they maintain in the UK or in the USA, we cannot maintain it. So actually, at least one dose of prophylactic antibiotic, I think it should be given to patients. Actually, you can take comments from partners from developed countries. actually we give.
Okay.
We give.
Rubina madam, in Pakistan, what is your practicing module?
So basically, when we are talking about the use of antibiotic over here, we are talking about patients who are in septic shock. So in septic shock, there are no two opinions that wide spectrum or broad spectrum antibiotic has to be given. If you're talking about routine cases like normal delivery and etc., we also give antibiotic.
Yeah.
So we
for cesarean section,
if
definitely.
it is cesarean section, but if it is a small procedure like MVA, normally we do not give antibiotics in the private hospitals, good private hospitals. But in government hospitals, even if you're doing an MVA, you will give a prophylactic antibiotic.
Okay, madam, thank you. Professor Kausar, we saw that many of the anesthetics give the antibiotic push to the obstetric patient. So actually, what is the ideal practice? The patient should get it from the preparation time, just 1 hour before the operation or 30 minutes before the operation, or in the preoperative ward room, or just before the operation. What is the ideal protocol? Professor Kausar.
I think you're the surgeon, you know better than me this protocol. But what we practice in our place is 1 hour before incision. So this is standard, I think, in the many standard centers. They practice this one, the antibiotics, IV antibiotics, 1 hour before incision.
Okay. So some institution practice 30 minutes before the incision and some practice 1 hour before the operation, but not just before the operation or after the incision. It is not
Blood level
practiced.
must be raised.
Yeah, because we are very busy here.
So in Pakistan, we do 30 minutes before the procedure.
Yes,
Before that,
minimum.
Dr. Sharmin, here is another question. I think Shardha sir can answer it. When the peripartum C-section should be done in a patient with shock?
Peripartum C-section done when patient with
The
shock.
obstetricians.
Okay, peripartum, if the patient in shock and patient have fetal distress, to save the fetus is the emergency situation, definitely. So you have to first encounter the shock, right? So you have to encounter the shock first with drugs, with anotropic drugs, with blood, with crystalloid, and then you can start your surgery when the blood pressure is a little bit up. I mean, when the mean pressure is above 60 millimeter of mercury, then we can start it to save the baby actually. If the baby inside is dead, so in that case, we can wait a little bit more time to blood pressure and hemoglobin level. It's bringing a little bit more up to save for the safety of the mother also.
Yes, sir.
So we can, but anesthesia plan will be different in that case. So this is when patient is
Actually, sir, our fellows want to know from you, what is your expectation from the obstetrician? Because patient in a shock, we need to do the emergency cesarean section to save the life and to save the baby. So there is a hurriness in the operation, swift operation, less time.
Cesarean section, actually.
Yeah, I got the point.
Actually a perimortem cesarean section.
Yeah, I got the point. Yes. In that case, we want actually a very expert hand on that time. So if some junior is doing the surgery and he is very lazy and he's very weak in surgery, so we asked him to call some senior people who is master on it. So because this is not a easy situation, a lot of charismatic work is required there. I have experience with the today's chairperson, Professor Laila Anjuman Banu Madam in Burdham 10-15 years back. When we got any problem like this situation, he come in the OT on that time and rescue the within 10-15 minutes, everything is under control. So expert hand is very important in this time. We will be unable to resuscitate actually because of you, because you are not stopping the output center, right? So what I am giving in the interval by peripheral lines or central lines, so you are outing, you are not stopping the output center, output
Yes.
side. So this is very important. An expert hand is required in this case.
Yes.
To shout for the senior people on that time.
Thank you, sir. Thank you.
Sharmin,
My question is
may
to
I add
Rubina, madam. Yes.
May I add
Obviously.
one point? This is actually, she wanted to know probably the perimortem cesarean section, and this is essential for patient's resuscitation. That if you do take out the baby, we can, in a better way, we can resuscitate the patient.
Thank you, Dr. Rosa, for this comment, because this is exactly what I was going to say, that peripartum cesarean section is sometimes lifesaver for the patient and also saves the life of the baby. So once the baby is delivered, the fundite reduces, resuscitation of the patient, especially if a CPR is required, that becomes possible. So I think peripartum cesarean section is of immense importance and is a life-saving technique. However, I would just like to add over here that proper informed consent from the family is very important for this kind of procedure, because sometimes the patient's family can say that our patient was dying and you were doing a cesarean section, so you contributed to the worsening of the shock. So I think talking to the family and proper consent is important for that.
Okay, madam. Thank you for your nice addition. We can take only 10 minutes time for rest of the question, because many question in our group also, in our OBGYN group, but due to time constraint, we not take all the questions. One of the question regarding the multidisciplinary team approach, Professor Rubina, madam, you have a vast experience with working with the South Asian region countries. So what's your opinion, madam, to deal all these questions? Some add that the inclusion of the hematologist also important in this sort of patient management. So MDT management approach, how is it is importance and how it is affordable for the developing country for us, because it's not easy to set the MDT level in all the sector of the healthcare system in our country also. So what's your opinion in a shortcut way to manage this sort of case?
Sharmeen, thank you for this. Is an excellent question, and it is very pertinent from our regional perspective. First of all, I think that I keep on talking to my trainees about it, that whenever we have a problem, if we get a call from the labor room that the patient is in shock, what will be the first response of our trainees? So from Pakistan, I can say, they will say, call the anesthetist. Call that person, call that person. So although we do try to promote the multidisciplinary approach, but at the same time, we want the capacity building of our own doctors. So I say that the first and the most important thing is that we should have capacity building of our trainees, of our junior consultants, to an extent that they should be able to make pertinent decisions on their own. That is one. The second thing is that the presence of obstetrical team, which includes an anesthetist and obstetrician, is most of the time sufficient, and we might not need more support, because this two-person team could be good enough to manage a patient. But hematologists, yes, hematologists would be required in certain cases when the patient is in a very bad shape, when you're giving massive transfusion or massive fluid replacement is taking place. I think a hematologist is helpful. So number one, knowing your stuff yourself. Number two, forming a team with a good obstetrical anesthetist. And number three, using the hematologist only if it is absolutely necessary. That is my take on this. Thank you.
Thank you, madam.
In
Professor
our
Zinatara Nasrin also
BSMMU,
with us. Yes,
Sharmin,
madam.
in BSMMU also, we had a team of anesthetists who will work for the cesarean section OT is fixed. And every time we call any problem, even in the labor ward, he will save us. And that is a rule in BSMMU.
Yes, BSMMU is our very fortunate university and the big tertiary area. But
the only point that I was trying to make was that sometimes our junior residents are too much dependent on the anesthetist, and the anesthetist on duty may be just a house officer. And because our doctors are so much used to calling an anesthetist, they would think they're doing the right management, which might not be so. So one has to be careful.
okay, madam, thank you. Professor Zinat, do you want to add anything, madam?
Thank you, Sharmeen. Actually, I was enjoying the whole webinar. It was wonderful and so illuminating. Our keynote speaker, our panelists, I mean, excellent. I'm really enjoying. And this is a very important chapter, very important topic. Thank you, PHA. Thank you very much.
Thank you, madam. Dr. Tasbih, sir, you raised hand. Do you want to add anything here, sir?
Yeah, thank you, Jinatapa, for your kind word. I want to actually echo Professor Rubina Sohail's comments on patient's involvement and family involvement. So it should be a patient-centered care. That means we involve the family or the patient from day one. Even we feel the patient education level is not that good enough, but still we have to talk at their language. Involve them from day one, family, patient. I'll tell you my experience. We started our ICU round. We call it multidisciplinary round involving the pharmacist, nurse, resident, physical therapy, dietitian, nurses. So we do round, and part of the family or the patient is in the round. When we discuss, they are present, either family or the patient or both. And we discuss, and then we just give the summary to the family, what's our plan and how the patient is doing. Trust me, we're doing it for the last 10 years, and our experience is so phenomenal. Patient satisfaction going to the roof, number one. And number two is the outcome is so good. And the family is so appreciating. Oh my God, I know so many doctors, so many nurses, the pharmacists are involved in taking care of my loved one. So please try to involve the patients and family from day one, and not just briefing, involved in the round kind of thing. You know, there should be a part of the MDR, the multidisciplinary round team. So I totally support Professor Rubina Sohail, what she said, that patient-centered care is very important. Thank you.
Thank you, sir.
For Dr. Islam. That question was asked in the group as well about repeating what he said about echocardiography for a patient with shock. So if you could please repeat it for us, I'm also interested, and the other people are as well.
Oh, sure. Actually, what we do, I'm the point of care ultrasound course director for the resident here. So what we do is we do the bedside echo, which is a part of the point of care ultrasound. And we don't need to look at the fancy thing or the MR, mitral regurgitation, aortic stenosis. No, we just look at the left ventricular function, right ventricular function, pericardial effusion, and looking at the IVC. That's what you need to know. So if you do the echo, any patient with shock, and if you see the left ventricle is not moving, this is a cardiogenic shock. If you see that big pericardial effusion, it is a tamponade. If you see patient has right ventricular dyskinesia or right ventricular dilatation, right ventricle is not moving, you think pulmonary embolism causing the shock. If you see IVC is collapsing, the diameter is less than 1 centimeter, and inspiratory collapse, you think of it is a hypovolemic shock. If you see the left ventricle is hyperdynamic, it's really contracting crazy, that means patient is either hemorrhagic or hypovolemic shock. So just putting the probe on the chest, you know what kind of shock you're dealing with. It's very simple. You don't need to do all, parasternal, apical, subcostal, parasternal, short and long axis. As long as you can get one window, either apical or parasternal or subcostal, the best view if you want to look at the left ventricle, the best view actually parasternal long axis. If you want to look at the right ventricle, the best view is the subcostal view. If you want to look at the IVC, the best view is subcostal view. So try to learn how to do the bedside echo. It's very easy. It takes maybe a minute or 2 minutes to get to see all the chambers and find out and what's going on with the patient. Thank you, Professor Rubina Sohail.
Thank you for this.
Thank you, Tasbih sir. I am just very short running of the time, so I'm taking one or two questions. I just saying some raised hand. Dr. Rukshar, do you want to add anything? If you want to add anything, unmute yourself, or Dr. Basma or Dr. Jahanara Mahmood. Anyone from the floor, do you want to add anything? Just unmute and add by 30 seconds. Anyone? I think no. So I'm just taking two last question. Dr. Raunam, do you add anything in here? One of our student asked that we are giving the low molecular weight heparin to the patient, and patient need the emergency cesarean section. Is it cause any problem for this sort of patient, or patient need to give any fresh frozen plasma for this low molecular weight heparin? Or after the operation, is the patient need to giving vitamin K injection? Dr. Rauno?
Heparin actually is stops 6 hours. 6 hours, and we can restart after 6 hours. And if we add Clexane, then
Madam, question is the patient need the emergency CS. The patient get the low molecular weight heparin, and after 30 minutes or 1 hour, she needs the emergency CS. So what is the protocol at that type of patient?
that is not, there is not any, for emergency there is no protocol, but actually when we give low molecular weight heparin, that is when we give actual heparin, we stop it 6 hours before, restart again after 6 hours, and we used Clexane, that is we use stop after 24 hours, and then again we can stop after 24 hours and start after 12 or 24 hours. That is our
So any role of post-operative vitamin K for this sort of patient, induction vitamin K?
Actually, I don't know. Anybody use
Anyone
vitamin?
from the
We
floor?
don't use. We don't use.
We usually don't use.
Okay, because in the chat box, some suggest to give the vitamin K injection 3 days if we do low molecular weight heparin and emergency cesarean section to reduce the bleeding. I think we don't have enough idea on it. So the last question. Yes.
Yeah.
Yes, madam.
Vitamin
And the last
sulfate is an antidote. Yeah.
Yeah. Last question for Dr. Kausar, that Dr. Fahmid Islam Chaudhary from Chittagong Medical College and Hospital. She is our assistant professor of this hospital. She wants to know actually what is the principle or the fluid management regime when we are dealing with acute kidney injury patient with sepsis. Just shortly, briefly, do you add, Professor Kausar?
Acute kidney injury
With sepsis.
with sepsis. Yeah, it's a common for the acute kidney injury is the previous day output plus 500. This is the gold standard protocol, but we have to monitor actually especially the central venous pressure. So central venous pressure, that is in the right heart pressure in the atrium, or at the end of the superior vena cava level. So this pressure is important, 0 to 8. So not more than 8 we expect actually. So because in 8, when the 8 millimeter of mercury in the right heart pressure, so it is good enough for the kidney perfusion pressure to maintain adequately. And of course, the blood pressure is, arterial blood pressure not less than 50 is to be monitored very properly. And you have to give the iron drops also to maintain that one. And fluid is the central venous pressure will guide you actually how much fluid you can give meticulously actually. So this should be the exact answer, I think. Otherwise, the other thing is 500 ml plus the previous day output. This is very gross thing actually. But important thing is what about your right heart pressure?
Dr. Kausar, one thing is, when you are dealing with this sort of the obstetric shock cases, what is the percentage of this patient after the operation they need to shift to the obstetric emergency to the ICU? Is a large portion of the patient, and I know in your institution you have a surgical ICU. So routinely all the patient you shift to the surgical ICU or not?
No, if any any adverse situation if happened in perioperatively. So that patient, sometimes we kept in the surgical ICU some patient with the coexisting disease, like patient have some cardiac disease like valvular heart disease, patient have cardiac myopathy, patient has other multiple comorbidities. So this type of patient usually we kept in the surgical ICU for the 24 hours monitoring. And any mishappening, we kept that patient in the, this is not routine actually.
Okay, and for this patient, regional anesthesia or general anesthesia, which is the best one?
It depends actually. When regional anesthesia always preferable for this patient, especially some situation we avoid regional anesthesia, like patient have shock, patient have severe aortic stenosis, patient have mitral stenosis, patient have own refusal, patient have some infections or skin disease in the back skin. So these are the actually contraindication for the regional anesthesia. Otherwise, we choose every patient for the regional anesthesia.
Thank you. Thank you, sir, for your fantastic discussion. We are near the end of the session. I'm just taking take-home message from our legends.
Yeah,
Yes, ma'am.
Armin, I
Yeah.
have got one question. I could not follow it. That you
Yeah.
are asking about the shock patients, about that is who has recovered from the shock and then the anesthesia, or what was your question? I could not follow.
The patient in shock and patient need the emergency operative procedure.
In
That was
shock,
the question. Yes.
I think, I don't know, here Professor Kausar Sardar is an anesthesiologist, so he will better know. But actually what I think that if a patient has recovered from shock, I should not suggest giving a regional anesthesia. I will rather prefer general anesthesia. I don't know.
Okay.
Yeah, well, we are saying like this in hemorrhagic shock. It's a strongly contraindication for the regional anesthesia, because regional anesthesia it suppresses the sympathetic system of the body, and what level of the blocks it depends on that also. So if a patient in the shock, it's absolutely contraindication for the regional anesthesia. So we prefer general anesthesia for that. Not only general anesthesia, in general anesthesia, we have to choose some special drugs for this one also. Like if you choose the propofol, if you choose the thiopental sodium, it's a wrong choice of your drugs. So you have to choose for that one. Ketamine is good. This type of patient, etomidate is good, or it's good for the co-inductions like all drugs, 2 or 3 combinations, but with very small dose.
Thank you. Madam, do you add anything more, Firoza madam?
No.
No. Okay, madam, we are near the end of the session. I'm just
might say something, I don't know.
the take-home message from all of you. First of all, Rubina madam, what is your take-home message for our trainee and the young doctor when leading this sort of cases? At the same time, you can give a question directly to you, madam, regarding fibrinogen concentrate. Does it have any role in major obstetric hemorrhage, or in our PPH bundle project, is it included or not? Professor Rubina Sohel, please.
Okay, 3 things that I want to say. The first thing is that the obstetrical trainee must educate themselves to the management, prevention, diagnosis, and management of obstetrical shock. They should think of working through multidisciplinary teams, but they should have the capacity to deal with the patients as and when they come. So that is my first message, and this is for the trainees. The second thing which we did not talk about is obstetrical HDU. I think that if a patient had a complication, whether it is an obstetrical shock or eclampsia, and even if the patient is stable, the patient should not go into. So the patient should be kept in something which is and I'm sure Professor Sardar is going to have a large experience about it. But obstetrical ICU is a very good place in between the ward and the ICU where the patient can be looked after. And most of the time, the obstetrical ICU is manned by the obstetricians themselves, who are basically trained for specialized need of patients who are serious. The third thing is that I think that we should know the concept of fluid replacement in patients with shock. So the formula that we use normally is 1:1:1. So 1:1:1. And the first thing is that we give one Paxil, we give one FFP, and we give one platelet concentrate. So we normally follow this formula, and this formula works pretty well to save the life of the patient. And you also avoid giving unnecessary fluids to the patient, not to overload the patient and cause a DIC. Thank you.
Yeah, it was great from the Rubina Sohail, madam. Yes, I want to add few points regarding these questions. So there is a few blood products what we actually transfuse. Number one is RBC, whole blood, platelet, cryoprecipitate, and fresh frozen plasma. So when it's indication is different actually. For everyone, indication is different. When there is a hemoglobin loss, so you should choose the RBC only. When there is a coagulation defect, there is especially when there is the fibrinogen count, you have to check the fibrinogen count. When fibrinogen count is below 100 milligram, it is usually the normal value is 200 to 400 milligram per DL. So when it comes down to 100 below, so you have to transfuse fresh frozen plasma. And 10 bags of your fresh frozen plasma, it will raise 100 milligram per DL. So it will come, if you start from the 100 milligram per DL, and it comes up to 200 milligrams, it will come to the normal. So when you will give the cryoprecipitate, when you need actually the coagulation factors, it's a very concentrated coagulation factor is the cryoprecipitate. From the 4 bags of the fresh frozen plasma, 1 unit of the cryoprecipitate is required. When there is a platelet defect, when you will count of the platelet is down, especially below 50, then you have to go for the platelet transfusion. So there is a very good analyzer machines is there. That is the TEG, T-E-Z. There is a thromboelastography. So this graph will tell you 1 drop of blood, it can say this machine what actually it requires. It is required platelet, or it requires cryoprecipitate, or it requires fibrinogen. So that's.
Thank you.
Thank you very much.
Thank you, sir. Yes, I'm taking last one line from you. What is your take-home message to the young fellows and the students regarding for management this sort of cases? Kausar, sir.
So for me,
yeah, just
so
in one line, what's your take-home message?
One line is difficult because every of what we have discussed here, we have discussed very superficial thing, intermediate and very deeper level, also critical management of this type of case also we have discussed. For the juniors, yes, for the juniors, be careful about your patient regarding pre-anesthetic checkup. So please check your patient before going for any operations, because if you overlook it, you may fall in some problem. And what is happening in our country very routinely, if you do it very routinely, I think you may avoid some difficult situation in your practicing life, and you should practice like this way. I think habits should be changed. I think. Thank you very much.
Thank you, Kausar sir, to giving your very valuable time. But I think it is very important, and you are the Secretary General of the Anesthesia Society. So Obstetrical and Gynecological Society and Anesthesia can work combinedly for the formulation of obstetrics pre-anesthetic checkup format or sheets It is a checklist for doing any obstetric cases, because we get the pre-anesthetic checkup sheet is a general, is not specific for the obstetric cases. So it's a timing demanding issue, and we can thought together for formulation of it. Thank you, sir, for joining with us. I'm just telling Dr. Rauno, you are just recently passed from fetal-maternal medicine. Yeah, do you have the LSS training in the fetal-maternal training wing, or what is your take-home message for the young fellows who are waiting to give the fetal-maternal medicine career? Just in one line, Dr. Rauno.
Thank you, Shaman. I just want to say that we have took BLS training in Dhaka Medical College and in BCPS, but I think that we can arrange a small workshops with critical care medicine department, and we can exchange our views and develop the criteria or admission criteria for HDO. And I see.
Okay.
Select the.
Can I add one line?
Yes, madam. I am just later take a mini take-home message from you. Just try to end of Dr. Rauno. Anything do you want to add more?
Just initial management and selection criteria. Thank you.
Okay, thank you. Dr. Nargis Fatima is one of the consultant of the biggest corporate hospital of Bangladesh. Dr. Nargis, do you want to add anything in 1 or 2 lines, madam?
Thank you, Shamin. Actually,
Yes.
I think it is a teamwork, and we should be vigilant regarding the. We should be looking closely the patient. We should take the deep history, and we should be always ready to manage any resuscitation procedure. It may be hemorrhagic, it may be hypoxic, it may be septic, or whatever it is. We should maintain the basic ABC for the immediate resuscitation, and we should call for help from our anesthesia as well as the critical care medicine, but the primary job should be ours, because we should, if it is a hemorrhagic shock, then it is the primary job is from ours, and we should adequately resuscitate the patient and take the immediate management for delivery if it is indicated. Thank you.
Thank you, madam. And we want to give you a big thanks, because in Bangladesh, the largest corporate hospital is leading by you and your team, and you are doing a tremendous job for the obstetric patient. Thank you very much, madam.
Thank you very much. Thank you.
Dr. Tasbih sir, do you want to add any take-home message in 1 line? And Professor Samina Chaudhary?
No, thank you, Sharmin. I think it's a wonderful discussion. I learned so much from the discussion and the presentation by Professor Firoja Begum. I missed the first few minutes, so I really apologize for that. But I think it is a wonderful session. And for me, actually, I learned so much from the panelists, rest of the panelists, the participants, and from the speakers. Thank you so much for having me. Inshallah, we'll do more and more sessions in relevant topics. Thank you.
Thank you, Dr. Tasbih sir. Professor Samina madam, in 1 line, what's your message for us?
What I found that important message from this seminar, that is, one is rule of 30, that is the shock index, and another important point that Rubina said, that is, we have to eliminate anemia in pregnancy, and they have got a program in Pakistan that at 28 weeks they are giving some injectable form, parental form of iron. And another very important issue we have learned from here, that is Professor Tajbirul said about the echo, bedside echo. I think this is a very important issue, that bedside echo for management of shock, we should learn it. That is the important issue, that is bedside echo we have to learn. Another important point is that the antibiotic use in sepsis or any shock, we don't know initially that what is the shock, what is the reason. So we have to use the antibiotic within 1 hour. So as early as possible, we should introduce it. And very excellent presentation from all of the presenter. Thank you very much for giving me.
Thank you,
to say
Professor
something.
Samina Madam. Dr. Rubina
And
Sohel
another
will
thing about
Yes.
Professor Firoza Begum, the lecture is excellent, and especially it is very important for our student, and it is very important for them this lecture. So thank you very much.
Thank you, Madam. Dr. Rubina Sohel wants to take a group photo. Yes, we can take a group photo. I'm requesting all to open the video. By this time, by opening the video, this time I'm taking the take-home message from Professor Firoza Begum. Professor Firoza Begum, what's your take-home message to your large number of students, trainee, and the young fellow? I'm requesting Dr. Kausar, Dr. Tasbih, Dr. Nargis Fatima, Professor Zina to open your video to take a group photo. Professor Firoza, Madam, please.
My take-home message, because as you have mentioned, there are many students. So I always say, take a careful history. If you see the patients very carefully, none of our patients will be anemic till delivery. So we should take the history carefully, examine the patient carefully. We can avoid this type of shock. And if we can diagnose the patient earlier, say a patient, cardiac patient, definitely we'll diagnose during the our antenatal checkup, not at the time of delivery. So we must be vigilant during our antenatal care, and it is very mandatory. I think our young generation should learn to give time to the patient, at least 15 minutes for every patient. Take the history properly, examine the patients properly, and then you can avoid many problems.
Thank you, Madam, for your fantastic message, and hope with your leadership, because you are the president-elect of our National Society. We have many expectation, many dream from you to fulfill. So Professor Firoza Begum, Madam, I think you are that sort of person who will always consider the mid-level and the junior doctor. Thank you very much, Madam, for joining with us. We are now taking a very fantastic photo. So please smile, everyone, and we are taking a photo, please. Thank you very much for the huge participant. I like to thank, because 160 when the lecture was ongoing, still 106 participant and more than 3,000 in our social media platform. So thank you for all for this fantastic addition. And lastly, my teacher, Professor Laila Arjuman Banu, would you please give vote of thanks and to conclude the session, please, Madam.
Thank you very much, Ramin.
Many ask about the next question. Yes, the next session will be the session of Professor Rubina Sohel, and she will talk on obstetrics violence. So all of you are inviting for our next session. I will give the date and time very soon. Thank you very much.
Charmaine,
Yes,
I saw some few in the chat box, many are requesting how to do the bedside echo. I'm more than happy to take a session on bedside echo, how to evaluate the shock.
Okay.
So it will be maybe 20 minutes, 25 minutes talk. Okay. So you can arrange that one. More than happy
we
to
can
do
arrange that.
Thanks.
Yes,
Yes, sir.
thank you.
Thank you very much.
Thank you. Actually, it is very essential. So again, thank you, every person here, and especially Sharmin to just conduct the session. First of all, I thank you, Dr. Tasbih Islam, and our two chairpersons. I'm sorry for my voice, actually, for that reason I'm speaking less. So our two chairpersons, Professor Farhana Dewan and Professor Rubina Sohel, who was very active in this session, and she put her so many important topics and important findings in this session. And our speaker, Professor Firoza Begum, and the panelist, Professor Kausar. I am giving thanks for remembering me the old golden old days in Bardem. Thank you so much. And the Raunak Akhtar for her beautiful moderation. Also Sharmin, above all Dr. Sharmin. I think everybody has been covered. 1 minute. We missed Professor Aushunara. I think she has some physical problem. And also Dr. Rehana Zaman. So actually, you have already heard that how much important is this obstetric shock. And still, after so much discussion, we have to know many more things. That means number one is the bedside echo. So it was a new thing for us, and I think Dr. Tasbih Islam is kind enough to have some special session for this topics. And I agree with Professor Rubina Sohail for her special word, that is the correction of anemia, along with the Pakistan and Nepal. And also I think in Bangladesh we are also working with this, and other chairperson, the implementation of PPH drill, which is also very important, because if we implement this not only in the theoretical, then I think the maternal mortality will come to a less, and also the obstetric shock. And we know that the blood is for blood. So when there is any risk factor, so we should identify the risk factors and prevent it by arranging bloods and the other crystalloid scholars like this. And so, and also manpower, so that we can cope this emergency specifically. So I must say that there is no alternatives than training. Actually, the management of the emergency patients, the training must be with all the obstetricians, because we don't have any obstetric ICU still now. Only started in Dhaka Medical College, I think so. But we shall have this obstetric ICU and HDO in all the big medical colleges and big hospital. So this is our urgent need nowadays. And above all, the main aim and the main talk is that no delay, be prompt. So very promptness is the main factor here, and no delay. Because if you think that whether I should do the hysterectomy or not, when there is excessive bleeding after cesarean section, then you will lose the patient. So without thinking anything, you just remove the uterus and patient will be saved. In my practical experience, I've seen that. So I again thank you so much for everybody, especially Charmaine, starting from Charmaine and Professor Rubina Sohail. She's along with us for a long time, and we are observing her smiling face and beautiful face. So thank you very much, Rubina, for joining us. And Dr. Tasbih, Professor Kausar also, he is a good anesthetist, also very, especially in pain management. And so the other persons also, Dr. Nargis Shoma and Raunak. So I think this was a very fruitful session, and I think our junior students and junior doctors have benefited a lot. And we are looking for the next session, that is the violence against women by Professor Rubina Sohail next. So thank you very much again. Good night to everybody.
Thank you, madam. Thank you. Thank you to Inceptor Pharmaceuticals, and thank you to United Hospital for the technical support. And Professor Firoza Begum, madam, many students want more classes from you, so you can keep it in your mind. And thank you for joining us. Thank you very much.
I can share this presentation, so
Yes.
you can give it to everybody who has joined. There is no problem. Yes. And Rubina, you have lost mass weight. I think I could not recognize your face even.
This is actually because I've tied my hair.
Yeah, maybe.
I think recording.
I am seeing you after a long time.
We
so
still remember your shopping in Pakistan.
Yeah.
Rubina, madam, just you can give message to our students regarding your session, madam. Just 1 or 2 lines. Obstetrical violence, you want to take? Yes. Yes. Thank you, madam. Thank you. So good night to everyone. Good night. Goodbye.
Okay, thank you, Charmaine.
Thank you.
Walaikum to all.
Thank you, Charmaine.
Excellent session.
Nice recording.
Sir, thank you.
Yeah,
nice
madam.
To see you again after a long time.
After a long time, yeah. Yes.
Thank you. Goodbye.
Goodbye.
And it's our great privilege, and we feel proud that Rubina madam stay with us the whole session. So it's a great achievement for us also. Thank you, madam. But Firoza madam, আপনার কাছে অনেক ক্লাস যাচ্ছে স্টুডেন্টরা, so think about it and give me a schedule.
Class তো ওরা আমি online নিতে পারি. If they want online classes, I am ready to take classes, because
Yes.
I am.
Give me some important topic for next sessions, please.
Yeah, tell them what topics they want. I will take online classes. because
Thank you, madam.
I am not allowed to take class in BSMMU, so I will take online classes. This is a sad thing that BSMMU.
No problem. We are in, so we can stop the recording also, PHA. And one thing is there.